Every second a patient spends in a modern hospital bed, they generate an immense volume of clinical data. Heart rates, oxygen levels, physician observations, and lab results pour into the facility's servers in real time. But a massive cloud of raw clinical information is inert. Without structural architecture to organize, route, and interpret those data points, they are useless to the healthcare providers who rely on them. For decades, managing this information conjured images of a medical records clerk filing away thick paper charts in endless basement aisles. Today, physical filing has been replaced by complex database management. The modern health information management, or HIM, professional operates as a specialized data architect. They build and maintain the digital pipelines required to extract tangible value from millions of individual health metrics. Without this architecture, patient data is a liability, an unmapped forest of information. When systematically structured, that same data becomes the functional asset that drives clinical and financial decisions. Most assume the electronic health record is the entirety of a hospital software. In reality, the EHR functions as the central trunk of a larger enterprise architecture. Parallel, purpose-built software engines receive data directly from that trunk. These engines process data through unique logic gates. The first node illuminates as financial processing software, translating clinical care into hospital revenue. The second node is compliance and disclosure software, mitigating legal risk and managing patient privacy. The third node is epidemiological tracking software, designed to monitor long-term population health trends. The EHR functions as the primary source record, while these secondary engines extract specific subsets of that data to drive a facility's financial, legal, and clinical operations. A physician's clinical notes are detailed, but insurance providers cannot process paragraphs of text. Those clinical narratives must be translated into standardized alphanumeric billing codes before a hospital can submit a claim. This requires encoder software. Coders use this tool to search the patient's health record and select the exact codes that match their specific diagnoses and procedures. Early iterations functioned as an automated codebook, essentially a simple digital index. Modern facilities use a rules-based encoder, which generates logical diagnostic suggestions based on the partial text a coder inputs. Once selected, these codes are fed into an algorithm called a grouper, which compiles the scattered diagnosis and procedure codes. This compilation outputs the MSDRG, or Medicare Severity Diagnosis-Related Group, dictating the exact financial reimbursement owed by the insurer. The grouper actively optimizes this return. If a complication or comorbidity is present in the record, the software prompts the coder to include it, qualifying the hospital for a higher-paying MSDRG. Simultaneously, the system runs edits to catch logical errors before submission, flagging impossibilities, like applying a newborn code to an adult patient or assigning a hysterectomy code to a male. This software logic optimizes legitimate hospital revenue by identifying missed coding opportunities while simultaneously blocking claims that contain clinical impossibilities. Moving to the compliance node, we find disclosure of health information systems, commonly referred to as release of information, or ROI. ROI systems are dedicated workflow managers. They are designed strictly to process, evaluate, and track incoming requests for protected health information. This flowchart outlines the decision logic for releasing a health record. The initial gate verifies the encounter exists in the master patient index. Next, it verifies the requested content meets regulatory criteria. Finally, the workflow mandates the requester provides valid proof of authority. Beyond processing requests, ROI software generates management outputs. It tracks individual employee turnaround times, monitors department backlogs, and manages revenue collected from customized patient invoices. To function properly, these ROI systems integrate directly with the hospital's admission, discharge, or transfer (ADT) information systems. This ADT interface auto-populates basic demographic data directly into the ROI workflow, eliminating the need for manual data entry and reducing typographical errors. By enforcing strict verification gates and integrating accurate demographic data, the ROI system transforms a massive legal and HIPAA compliance risk into a controlled and auditable workflow. The final node belongs to epidemiological tracking. Unlike financial or compliance software, which handle immediate hospital operations, Clinical registries abstract data to track long-term population health. The Cancer or Tumor Registry is a complex dataset used by healthcare facilities to report localized epidemiology to state and national health agencies. This interface shows a cancer registry staging module. Notice the granularity required, with specific fields for abstracting precise topographical sites and ambiguous terminology. It also requires tracking the exact number of positive regional nodes to determine the exact staging and severity of the neoplasm. This data collection isn't isolated to a single visit. These registries track a patient's continuous treatment modalities and clinical follow-up progress from the exact date of their diagnosis until their death. A distinct parallel system is the Trauma Registry. This software tracks patients suffering from severe physical injuries, logging data from their initial emergency arrival through their post-hospital care. Trauma registrars rely on specialized scoring algorithms to quantify damage. They begin with the Abbreviated Injury Scale, or AIS, which maps the location and severity of the trauma based on the specific body system affected. That data feeds directly into the Injury Severity Score calculation. By mathematically combining the AIS of the 3 most severe injuries a patient has sustained, the software helps predict the overall potential for morbidity or mortality. Through strict scoring and continuous tracking, these registries abstract immediate patient crises into predictive data models. Those models then dictate broader public health practices and resource allocation across the country. When we zoom out, we see the complete enterprise architecture. Vital signs and physician notes hit the central EHR, and that data flows simultaneously into the encoder's ROI workflows and registry notes. This network is engineered for 2 specific goals. The first is efficiency. An encoder, for example, increases a coder's productivity and speed, achieving the desired financial outcome without wasting time or personnel. The second goal is effectiveness. These same systems ensure thoroughness, such as prompting a user to capture the most accurate MSDRG possible, ensuring the actual stated outcome is successfully attained. Overseeing this vast technological landscape requires executive leadership. Positions like the Chief Clinical Informatics Officer, or CCIO, guide clinical providers in adopting these systems to improve the quality of care. They are supported by specialized operational staff, including data integrity analysts who enforce compliance, and mapping specialists who ensure diverse vocabularies align across all interfacing systems. The software architecture driving a modern hospital is powerful, but it requires highly specialized human oversight to ensure those data pathways remain functional and accurate. Managing this ecosystem demands rigorous hard skills. Today's HIM professionals utilize SQL programming, design relational databases, and perform complex predictive modeling. But those technical capabilities must be paired with soft skills, the critical thinking to interpret government regulations, and the clinical judgment to understand the reality behind the data points. Health information management is the active, multidisciplinary engineering of the clinical data pipeline. Every diagnosis and reimbursement claim depends on the integrity of this data architecture, placing the HIM professional at the center of the modern clinical pipeline.